lots of times when people are assessing the hamstrings, they'll just bring the leg straight up like that. Now you are a little short. And up here. You gotta hold this one down when you're doing that, otherwise this comes up and you get a false read on it. Okay? To find out if it's coming from the hip or from the knee, you've got to take the knee out of it, or the hip out of it, and then have them straighten their leg. And he's short at the lower part.
But my hip is allowing for past 90.
So we could do a muscle energy technique on here, which would be push down, contract, relax, antagonist, contract, take it up, 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 up. Do it again, contract, relax, antagonist, contract, up, 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 up.
Okay, farther.
Oh, that will improve, yeah.
Yeah. Up, up, up,
So
up, up,
what
up.
would you call that technique there?
This is contract, relax, antagonist, contract,
yeah,
like that.
I do it a different
Yeah.
pattern.
But this is
See,
better
you're doing
than-
it over again, so that's cool. I do it over again too.
Yeah. Now we can check and see if that changed the length of the hamstring altogether. Okay, bring it up. Up, 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 up. So we got, you know, people would think, oh, I'm tight up here at the hip. That's the biggest error. It's almost always at the knee. So you need to do what, you know, I could have massaged that. I could have used inhibitory pressure. I could have done a lot of stuff. I just chose that particular intervention with it. The key takeaway is, well, it's usually short at the knee and long, and has problems with its firing pattern at the hip. So again, you already know how to massage a leg. Let's add some other elements into it that makes it more efficient. Okay, I'm done with you, Luke Allen Fritz.
And in general, this is how you can think about the tendency for people's compensations is that they're basically trapped in seated position. So where are the Ks, where are the hills? Short, long. So anterior knee, stuff tends to get long. That's why there's the rubbing, but it's short at the hip. You flip it around, posterior, long, short, and there you go. And that'll reinforce kind of where more focus should be done during the massage part.
So the things that we're going to practice, and I'm going to defer this to Luke, coming up, are why, how do we gauge that muscles that are contracting to move the joint in a sequence that's going to produce the movement that we want and not strain the joint structures. There is a pattern on how we're supposed to move. So the first one you see up on here is going to be hip extension, and then oftentimes what you're going to find is the hamstrings are going to fire first, and it should be the glutes. So the correction will be inhibit the hamstrings and have them fire the glutes. Knee flexion, it should be the hamstring. But if they're using their hamstrings for extension, then they're going to have to use their calf for knee flexion. And they're going to get a stiff, painful, fat feeling behind their knee. Anybody heard them say that? It feels stuck or stiff or fat behind the knee. So in that situation, we would inhibit the calf, usually with just pressure on it, and have them produce the movement and see if we can't get the hamstring to contract correctly. Then the next one would be knee extension. And this is the one we've talked about a little bit with making sure that vastus lateralis moves and contracts first so, or vastus medialis, so that it can pull that patella into proper tracking. That's an alternate position there. So this afternoon, Luke is going to work with you. That's hip extension, or
abduction.
yeah, that's abduction, adduction. Luke is going to work with you on. There's where I want to get. These firing patterns that will work along with the knee and the hip and the ankle. Now the ankle doesn't have a lot of muscle activity with it. When you do a squat, you should be able to get your knee without lifting your ankles. You should be able to get your knee to your toes. That'll tell you you got enough flexibility
over the toes, where you can't see your feet anymore.
Yeah. And when I do that, I can do it with this one, but this is the one that's got all the compensation. So the decision would then need to be made, is this the best the knee can do and maintain stability? Or could I get better function if I would loosen up one of those elements? And the issue becomes, I'm maintaining stability in the knee because my gastroc is shortened, which is affecting what my ankle mobility is. So sometimes you got to just be close enough.
And that's a good example. So this is ACL related, which keeps the femur from tracking anteriorly. Her gastrocnemius is able to hold on to that femur and is compensating for there not being an ACL. Thus, in her, if she was the client on the table, we don't want to bring the tone down too much on gastrocnemius, especially right there behind the knee, because now that'll destabilize the knee. And that's just going to be the journey where you have to mediate how much are you going to do based on, ultimately, if the symptoms are reduced and the person's able to functionally do the things they want to do, then that's a victory. Right?
Yeah, call that good enough. And I think massage therapists want things perfect. And you got to kind of learn your professional identity is not tied with necessarily the results you get. It's and results don't happen overnight. That little bit of a change I had in Luke's leg there, that's very temporary. You got to sort out why it's like that, and I would ask some questions like, well, what have you been doing? Is there a past injury with that? Have you got a logical reason why your hamstrings are a little tight at the knee? I mean, I would see if I could make sense of it. And sometimes I can, sometimes I can't. So, but you don't want to fix what's not broke. This is not broke. It's compensated, it's adapted, and when I bend over in the garden like this, stiff today, but I'm actually pretty hypermobile. Getting down that far is not necessarily ideal, and all this connective tissue is trying to keep me from doing that. But my knee has been, the calf has been stretched out, and my knee has been wobbly. And I have to be careful. So the other alternative is to flop onto the ground and crawl around in the front yard, which has got its own hysterical. I've heard Luke say in the past, well, somebody will say, where's your mom? Oh, she's crawling around outside in the front yard. So, we need to honor how people are doing what they want to, they're getting it done. They're getting the job done, so. And then the final piece is to come back up and make sure that when we're thinking about this pelvis here, the other one would be better.
got it.
So here's where that SI joint is. It's lost its screw. Oh dear. All right, you can see the gap in here on this. Somewhere around here there is a screw.
Don't pull apart more.
This goes in there. This needs surgery. Oh, the screw is in there. It's lost its nut. Is the pelvis should be firm at the symphysis, solid at the SI joints, and not too much movement like that. And that's what Luke's going to work on, because you already mentioned my pelvis, to accommodate that wonderful knee thing she's got. She's got this anterior rotation going on. So it can be anterior, where the anterior superior iliac spine goes forward, or posterior, where it comes back, or an in flare, or an out flare, or it can be one going one way and one going the other. It's the struggle I have seen with students is being confident that they're assessing for an in flare or an out flare. Or
Anterior.
you can tell I'm getting tired. An anterior rotation or a posterior rotation or an in flare or an out flare. So what you just kind of do is correct it all. And so that is how he approaches that, and see if we can't get a nice solid set right there with that. That's going to work down the chain with stuff. So that's where we're at for the afternoon.